Okay, disorders of fluid volume. This hopefully will be relatively short. The physiologic consequences of the disorder is going to depend on the type of imbalance. And you can't really talk about disorders of fluid volume without also including some about electrolytes. So this says disorders of fluid volume, but we might throw in some things about electrolytes as well. So again, we're looking at interference with perfusion and oxygenation, interference with cerebral function, and interference with neuromuscular function. So when we have changes in extracellular fluid volume, we have changes in potassium, magnesium, and calcium, we're looking at problems of perfusion and oxygenation. When we have imbalances of sodium and water, we have problems with osmolality, and that, of course, is going to interfere with cerebral function. And then if we have problems related to potassium, magnesium, and calcium, then that interferes with the neuromuscular function. Under impaired perfusion or oxygenation, specifically about fluid, if we have fluid volume deficit, then we have decreased perfusion because we've decreased the arterial pressure or the blood pressure. And if we decrease the pressure, then the blood can't circulate everywhere. It's not going to get to those smallest capillaries. Which, of course, that is going to affect oxygenation, because if we don't perfuse every area, then every area isn't going to get oxygen either. Fluid volume excess also impairs perfusion and oxygenation. When we're talking about fluid volume excess, we're primarily talking about edema. We're talking about a buildup of interstitial fluid. It could be within the vascular space as well, and that's going to cause, still going to cause perfusion problems because too much volume prevents good circulation as well. But when we're talking about interstitial fluid, and we're talking about edema, so this edema, this fluid buildup between the cells, actually pushes the cells farther away from the capillaries, making the oxygen travel farther to get to the cells. So we don't have as much fluid circulation in the interstitial fluid. Remember when I talked about hydrostatic pressure and colloidal osmotic pressure? We've got that buildup of interstitial fluid. That interstitial pressure is going to be higher, and so we're not going to get as much fluid moving out of the capillary, of the arterial side, and obviously there's some reason why it's not moving back into the venous side. It's staying there in the interstitial space. So we're not getting new fluid brought in. Oxygen has farther to travel. And so, if you think about it, that lack of oxygen, that lack of new nutrients is the reason why we're going to have delayed healing of edematous tissue. Okay? The most classic example probably of fluid volume excess would be pulmonary edema. Again, we've got fluid in a place where it's not supposed to be, and when we have pulmonary edema, the fluid is trapped not only within the alveolar sac, but also in between the spaces of the cells of the alveolar wall, and that is certainly going to interfere with gas exchange. We've got all this fluid keeping oxygen from coming in and getting to the alveolar wall and the capillary wall, And then we've got all this fluid that's preventing carbon dioxide from going the other direction. So gas exchange is impaired, partly because perfusion is impaired, partly because there's just a roadblock with that fluid that's built up there. The other thing that's more of a can be more of a fluid volume issue is impaired cerebral function. And again, it's hard to separate out sodium from water, and so what we're really talking about is osmolality, or the concentration of the fluid. So if we have a dilute plasma, meaning we have more water than sodium, then again water is going to move into the cells and we're going to see a change in LOC. If we have too little water and too much sodium, water moves out of the cells, we're going to see a change in LOC. So kind of you see a repetitive theme, and what you want to do is move beyond that, and how does it apply to you? So what does it mean? Well, I mean, it means that I've always got to be cognizant of my patient's level of consciousness. If they have a change, is this new for them? Is it different? And if it is different, what do I need to start assessing? Well, has their blood pressure bottomed out? If so, why? You know, and where's it going? You know, not the blood pressure, but the fluid. You know, that's why. You know, have they suddenly had vasodilation? You know, whatever. My patient has edema and a cut on the leg. Well, that's going to impair healing, and so I need to take measures to improve that. And what am I going to do that? Okay? So sodium and extracellular fluid volume, that's what ECFV means. Again, I think I probably have beat this to death, but the amount of sodium in extracellular fluid is the major determinant of the size of the extracellular fluid volume. As a general rule, if sodium increases, extracellular fluid volume increases, because sodium attracts water. So we can have fluid volume overload, or edematous states. Remember that typically if a patient has edema that we are observing in their legs, they probably have edema other places that we can't observe, such as edema of the organs. Many people will have, for instance, when they have too much fluid on, have diarrhea. Why do you think that is? Does the fluid cause an increase in motility? Not necessarily. But what's happening is that the tissue of the intestines is edematous, and that fluid is moving into the feces and being excreted. They might have right upper quadrant pain because of the backup of the fluid into the liver, which is going to cause liver damage. They may have nephrotic syndrome, which is a renal disorder, simply because with that increased volume, they may have decreased perfusion. And then pulmonary edema, always a possibility. Pleural effusions, meaning fluid is building up between the pulmonary, the pleural membranes, you know, those two membranes that cover the lungs. That's called third spacing. Ascites, which is buildup of fluid in the abdominal cavity, is called third spacing. So it's third spacing is fluid in a place where we can't use it. You know, once it's in the pleural space, we can't really use it. It's not going to go back to where it belongs. on its own typically. If sodium decreases, then as a general rule, extracellular volume will decrease, leading to volume depletion. There's nothing to attract the fluid there, so it's going to go away. So fluid volume deficit is a decrease in extracellular fluid volume. Can be caused for excessive fluid loss, such as diarrhea, a large wound that is draining, burns. You lose tons of fluid through a burn. Obviously, if they're not taking enough in because they've got nausea or vomiting. So any of those things combined can certainly cause a decrease in fluid volume. So obviously we're going to see a lot's going to depend on how quickly the fluid volume declines. If it's a slow decline, we may not see very many symptoms initially. We may get all the way to poor skin turgor, oliguria, dry mucous membranes before we really see any other symptoms. Those things don't occur rapidly. If it's a rapid decline, then we might see a significant drop in body weight, orthostatic hypotension, tachycardia, weak pulses. That tells us that there's not enough fluid in the vascular spaces. Now, if we're going to correct that fluid volume deficit, the first thing we want to do, if possible, the best way is to use PO replacement. Get the patient to drink. Not always feasible. So the next best thing is IV. And just to go back to PO, think about the reasons that PO might not be reasonable. If they're nauseated, if they're having significant diarrhea and they're losing it as fast as they're taking it in, burns, significant burns, you're not going to be able to get enough fluid in by mouth to overcome the fluid loss. So obviously we have to look at the patient condition. Now when we're looking at IV fluids, we need to think about the types of fluids. When we're talking about types of fluids, we're talking about hypotonic, isotonic, or hypertonic. Now hypotonic fluids, remember, have less sodium. They're less concentrated than serum or plasma. We usually will use hypotonic when we want to replace water but not replace sodium. This might be done in cases where we want the fluid to move from the intravascular to the interstitial spaces so that it's available to move into the cells. Isotonic fluids have the same osmolality or concentration as plasma. We use isotonic fluids to restore intravascular volume. We want it to stay in the bloodstream so that we can increase cardiac output or increase perfusion. Hypertonic solutions have a higher osmolality or higher concentration than plasma. So this is kind of putting more salt into, or sodium, into the vascular system so that we draw fluid out of the interstitial spaces. Again, this can increase cardiac output and perfusion, so we can perfuse the kidneys better and promote diuresis. So typically, we're going to use hypertonic solutions in cases of fluid volume overload as opposed to fluid volume deficit. Unless, of course, we want to move it into the vascular system out of the interstitial spaces. We can also use volume expanders. These are colloids, the large proteins like albumin. They stay in the vessels. They're not going to move back and forth. And so they simply draw water into the vessels. And these are going to restore intravascular volume so that we can get that blood pressure up. Fluid volume excess, obviously caused by an abnormal retention of water and sodium, as a general rule. It's always secondary to an increase in total body sodium content. So we're going to have an increase in sodium. It's just not maybe where it needs to be at the right time. So serum sodium levels often will remain the same because the proportions are equalized in that the fluid shifts. Sodium stays the same, but the fluid shifts from one place to the other. So we have adequate fluid volume in the intravascular space, and the fluid shifts to the interstitial spaces, and so we're going to see that as edema or pulmonary edema or whatever. We might see it with certain types of endocrine conditions, cirrhosis of the liver, taking in too much salt, especially with decreased renal function. And keep in mind the changes that the elderly go through. They have a decrease in total body water, and so a little bit of fluid given to them IV can push them over the edge. They have a decrease in renal function, so they're not able to adjust to changes in fluid volume as easily. They have a decrease in cardiac output, so their kidneys aren't getting perfused, and their hormonal regulation is going to be somewhat delayed. So their RAA, their ADH, their ANP, all of that is going to change. They have a decreased thirst sensation, so maybe somebody's forcing fluid on them. So obviously the primary thing we're going to see is edema, crackles when we listen to the lungs, bounding pulses. Could be that we'll have an increase in blood pressure. So we want to look at all those things. And then frequently what we do for fluid volume excess is to give medications. And typically we're going to give diuretics. And your diuretics, are medications that increase output. And they work in the kidneys at the tubular level. And so the picture is of a renal tubule, and it's just kind of showing you where some of the different types of diuretics work. Most of the diuretics act on the principle that water follows sodium. So most of them inhibit sodium reabsorption in the renal tubule. So sodium stays in the urine and is excreted. And as long as we have sodium in the urine, it's going to draw more water out. The greatest amount of sodium in the urine or in the renal tubule is in the loop of Henle. And that's that thin little loop that goes down. And so that's where most of our your loop diuretics are going to work. So loop diuretics are like Lasix, and they work very quickly and are very effective. And the nice thing about Lasix is that it works even if we don't have good renal perfusion. So we can still get that fluid off even though the kidneys may not be functioning as well. Thiazides and thiazide-like diuretics, these are your hydrochlorothiazide. You can see they work more in the descending portion of the tubule. I think it has a name, but I don't remember it. There's less sodium there, so they're not as effective as the loop diuretics. And then we have the potassium-sparing diuretics, and this is like spironolactone that actually excretes sodium in exchange for potassium. And so most of your diuretics lose potassium as well as sodium, but your potassium sparing do just what they say, and they keep potassium. So you want to be aware of how is my diuretic affecting the potassium. And then your osmotic diuretics and carbonic anhydrase inhibitors typically are given under controlled circumstances. So an osmotic is like mannitol, and it's usually only given in ICU, and typically only for like cerebral edema. So side effects, if you think about it, you can probably figure out what the side effects are, because your side effects are related to their action. So what is their action? They're getting rid of fluid. And what is the result of that? For getting rid of fluid, well, initially they're getting rid of salt. That's their primary action, but we give them to get rid of fluid. And so we're getting rid of fluid, and we're causing that fluid to shift from around the cells to inside the vessel. And so what are we likely to see? We're likely to see that the patient is dry, so dry skin, dry lips, dry tongue. We get rid of too much sodium, then we're likely to see lethargy, change in level of consciousness. If we get rid of too much potassium, we're likely to see muscle weakness, tachycardia. And if we get rid of too much volume, then we're likely to see hypotension. It removes the fluid from the vascular system first, and then the fluid will shift from the interstitial spaces into the vascular volume. And so it can take time for that fluid shift to happen. So we're not going to see an immediate decrease in edema, but we may see a fairly quick decrease in blood pressure as a result of losing that fluid out of the vascular system. So we could lose too much fluid, too many electrolytes like sodium and potassium. We also have to look at other medications that they're on. If they're on digoxin, what happens if they lose too much potassium? What happens if we're giving them a loop diuretic and they're having a ham sandwich and pickles for lunch? We're kind of defeating our purpose, right? So we want to look at their diet and the things that they're taking in, like caffeine or alcohol, foods that are high in potassium, depending on the type of thing that they're taking. Okay, into that. The last one I think is acid-base balance. So hope it's good.